There are times during surgery when you discover a way to make things easier or more efficient. Sometimes there are through our own quicksand moments. Others are surgical gems gifted to us by our mentors and peers. This is OQC Eureka Moments with Doctors Nicole Fram and Elizabeth Yu, where we learn how to pivot, reflect, and evolve as surgeons. Hi, everyone. Welcome to another season, brand new season of Ophthalmology Quicksand Chronicles Eureka Moments. This is another one where we are coming out of the dark and talking about the pearls. We are your hosts. I am Dr. Elizabeth Yu, and of course, with me is none other than the wonderful.
I'm Dr. Nicole Fram. Liz, we had so much fun in season 3 with Eureka Moments. I learned so much from our amazing guests, and I hope everyone did as well. And we couldn't wait to return for season 4. This season focuses on those moments. So you're in surgery, you've had the quicksand, you watched all our episodes, you understand how to handle it. And then now there's these moments where you learn from our incredible guests and experts and everything that we went through together how to make things easier. This whole thing is about how to make it easier during
I
surgery.
know. Yeah, like we talk about, obviously when things don't go perfectly, but we want to climb out, and I can't do it without doing that. Coming out of
Oh,
the
here we go.
dark. Oh yeah, I know. I'm so tone
Oh, I
freaking
mean,
deaf.
I know,
I
but
know.
but you keep trying. It's your perseverance that I
Oh
love the
my
most about
gosh,
you.
thank you.
Yeah.
Well, as a reminder to you guys, this season will be available, of course, on the ASCRS website. You can find us on YouTube if you want to see and listen, or you can hear us on your favorite audio podcast platform. And if you could so kindly give us your feedback, give us 1 minute of your time and fill out the survey in the description below. So, Nicole,
Who do we
who
have?
is our guest?
This is one of my favorite people. We came up together. This is my partner in crime, my brother from another mother. He is hilarious, brilliant, and so generous with his time that he's even willing to hang out with us. I We would like to introduce our amazing guest today, Dr. Sam Garg. Now, Dr. Garg is the chief medical editor of iWorld. I feel like iWorld really just like has come up now. I mean, no offense, but it's like it's got some swagger now because, Sam's there. And he
Yeah.
serves on the ASCRS Executive Committee and the Cornea Clinical Committee. He's also served on ASCRS on probably every other committee during his tenure. He's the vice chair of clinical ophthalmology and the medical director and professor in cataract refractive external disease and corneal surgery at the Gavin Herbert Eye Institute at the University of California, Irvine. Sam, we are so honored to have you here today. And what a better way to spend a morning than with one of our best friends.
Let me tell you, um, Dr. Eric Donenfeld has swagger. Sam Garg has swagger. I mean, to fill Dr. Eric Donenfeld's shoes to be the chief medical editor of iWorld after him, it takes a big man.
It
Sam
does.
Garg, what's up? I love that we have Sam here with us today, and it is true. I mean, we, Nicole, Sam, myself, we're all like contemporaries in terms of like we're in this like we're now kind of approaching 20 years
No, we're mid
together.
mid. We're called
I
mid.
know.
Okay, so
Oh, sorry,
don't
mid,
yeah, we're mid.
whatever. Okay,
Okay, we're
mid.
not
But okay, sorry, we're not like the young, you know what I'm
we're not
saying? It's
I know.
great. I'm just saying we're like in the same stages of, and it's just great that we're doing this together and we're at this stage, and I love watching it, and I love that we've been able to do this together. So remember, this podcast is all about how we discover a way to make things easier from surgical perspectives, pearls. Sometimes you just hear things in your head and you see things, just subtleties. And so we can hopefully prevent the problems from even happening because there can be little signs that we recognize as surgeons. And Sam is going to teach us not just one thing, but lots of things. So, Sam, please take it away.
Well, guys, what an honor to be here with you both, two of my closest friends. And I echo everything you said. Coming up together in ophthalmology has been so much fun, and really so honored to be here sharing this case. So we'll just get into it. So this is a case we all get second opinions. This was a fourth opinion. This guy came to me for cataract surgery, and you can see a pretty dense cataract here. Pause it just for 1 second, if you would. Let me give you a little background on him. He's a 65-year-old PhD, super duper type A, super type A. So he saw several local surgeons, then went up to the Bay Area to see another surgeon. And I was blessed that he came back to me, and blessed is certainly tongue in cheek there. Um, History of an RD. He wasn't sure how long ago. He had a sensory exotropia. He was on Flomax. You can see a pretty brunescent cataract here. Vision was better than what I had expected, 2200, but with a little bit of glare, dropped to light perception, and he had a myopic shift. So we can start the video here. You can see here, I use the catalyst laser to help me with this case. And so pre-soften the cataract, and now I'm removing the cap of the capsulotomy and trying to perform a little bit of gentle hydrodissection here. I wasn't sure of his zonular status. And so as I'm hydrodissecting here, you can see the lens prolapsing up. Again, trying to be gentle. One of the challenges with these dense ones is, how to figure out how to get it to move without really damaging the zonules much. I was anticipating some zonulopathy, and I've learned from my good friend Nicole here how to manage those patients. So I wasn't able to get a good spin, you could see there, but you could see here he has quite a bit of zonule loss. And so now the question is, how do you remove this lens without having the whole thing deep six on you here? And so trying to use the pre-fractured cataract and try to break off pieces so I can get it to come up. Pause it for a second here, if you would. When a case is like this, Nicole, what do you do here? Do you keep going, or do you put in hooks? How do you manage something like this?
Yeah, there was that red reflex sign and you saw kind of the capsule crinkling and that was your cue. Sometimes bringing everything up into the anterior chamber or tilting it on its side, exactly what you're doing is the best thing to do. If you're going to put in capsule retractors, you got to get everything back in the bag. And sometimes you're scared to kind of push everything back down because, there's no vitreous there, right? So he's had a vitrectomy and things can happen so fast when there's no vitreous. So I really love what you did, put in dispersive viscoelastic, bring it on its side and try and do as much as you can in the anterior chamber at this point, not using, kind of a super capsular approach and not using the capsule and counter traction for the zonules any longer.
Yeah,
So
start the
one
video.
thing, wait, hold on 1 second. The other thing for anyone who's listening, it's about a 3.5 to 4 plus brunescent NS. Um, and obviously it's been a femto created capsulotomy, and that's always a concern that, that the strength of that capsulotomy may not be super great when you're kind of prolapsing a lens into the AC. And I always think about that for consideration whenever I'm doing a supracapsular kind of approach, because that's not a common one that we generally do, between Sam and Nicole. It's a great approach, but I use that more for like the very soft
Soft.
lenses. But in a case like this, just like you mentioned, you don't know when that capsule could come up. And right now, you have a healthy cornea and you want to preserve the capsule as much as possible. So as soon as I see that the lens is up, and I see that capsule starting to kind of, wrinkle in the wind or, flop, I will actually put in more dispersive viscoelastic into the capsule
Push
just
it
to
back.
kind of push it back. And I won't interrupt again, but I just wanted to mention that's just a little bit of something extra. If I feel like it's not enough that I feel that I need to put in anterior capsule hooks, but I'd like a little protection. And then why not? Because that'll kind of, I can put a little bit into the anterior space for that endo protection, plus push the posterior capsule back a little too.
Yeah, I agree. Start the video if you would. So, I think a couple considerations here in this patient. When there's no vitreous to sort of help support the lens, it changes the dynamics quite a bit inside the eye. Putting capsular hooks in is not always easy, and it always, doesn't always support it the way that you want. Sometimes it'll slip out. So,
Especially with a deep chamber. Like they come out planar. It's really hard. We don't have any that go, so deep to
right.
capture.
So I agree completely. Placing more viscoelastic into the eye is helpful. What I'm trying to do here is just get one piece up. And once you get one piece up, it sort of becomes a little bit easier. I'm using, you can see here, I'm going to place some more dispersive viscoelastic for two reasons. Number one, to stabilize the chamber. Number two, to help prevent any significant corneal endothelial loss, which is, he's at higher risk because it is a relatively dense cataract. And if I am going to get this into the AC, I'm going to end up phacoing closer to the endothelium. And so trying to chop and finally get a free piece here and able to take, oh, no, maybe not. Should have taken that, but kept going for the bigger pieces back behind here. And you can see it's just a stubborn lens that doesn't want to come forward. And one thing that I think can be helpful is using your viscoelastic not just on top of the lens, but behind the lens. And I actually learned this from my mentor to try to go and create a sort of an artificial epinucleus in these denser lenses. So I tried to put a little bit behind the lens there to try to keep that capsule from breaking. And even though he's had a vitrectomy, you don't know how complete that vitrectomy was. And placing lots of viscoelastic. So these are cases that I'm asking even before I start the case. I'm making sure my staff has multiple vials in the room rather than them having to run and go get it. And again, just taking my time, trying not to be too impatient here. And I know as surgeons, sometimes we get to be a little impatient, but and trying to get the pieces to come up as gently as I can. You can see here, I get it coming up there. And what's hard to tell is what's going on with the actual capsule. And the capsule was remaining, fairly, it was behaving itself because there was viscoelastic sort of keeping the bag open, if you will. And
So what type of viscoelastic are you using?
I'm using Helon Endocoat.
Mhm.
Any dispersive viscoelastic is helpful here. And you can see finally getting pieces to come up and just trying to chop them so I can be as friendly to the endothelium as possible. On the J&J machine, they don't have a CDE, but they do have something similar. And that number keeps climbing here on the left. You can see the EFX number, which is on the left. And they recently changed it. It used to be higher, and then they divided it by 10. So, this is back to the way it used to be, like over 100 at this point, 111, 120, excuse me. So I'm just struggling with the lens, trying to maintain the bag and really try to prevent pieces from falling to the back. This was a gentleman, again, with a retinal detachment. And his history on that was sort of unknown for sure exactly how they repaired it. I didn't see a buckle. I had no view to see if there was any laser back there. And he was tolerating his myopic shift, which is why he let it go for so long. When I talked to him, he mentioned that this has been going on for a good 5-7 years where this cataract was getting worse. So you can see the cataract came out here. If you could pause it here. So Liz, at this point, what are your options? What do you want to
Yeah,
do? You can see the capsule is
yeah.
quite floppy, but the cataract's mostly out. There's some epinucleus left.
Yeah. So right when you were taking out that last piece, we could see that nasally, one, the pupil is starting to come down a little bit just because the eye has been somewhat floppy. So we recognize that that has caused some turbulence. And as you were removing, and the capsule does appear intact, but it was very obvious that there's about, at least half of
Yeah.
the equator is missing zonules. There was a very obvious clear zone. So, this is going to be where even if you did make the attempt to, let's say, stabilize everything, put in tension segments, do whatnot, honestly, it might be for naught. It may be a really, really good effort, but it's actually um, you say to yourself, do I do all that in someone who's already been vitrectomized, or do I say, okay, this patient's been vitrectomized, I'm not creating more traction, and do I just go ahead and say, we know that I'm not going to be able to do a really good cortical removal, and there's not really great amount of time. Let's do a scleral fixation. I can get that done safely, and we can go ahead and move on doing that. Intrahaptic, flange scleral fixation, glue fixation, whatever is your preference of choice.
Mhm.
Or if the surgeon at that point says, let's abort, leave him aphakic, and send it to someone, that's also an option. For me, I would go with option two, likely in this case, just because I don't think that a CTR plus or a kind of Sione double islet CTR would even be a great way to stabilize this. I think it's going to be very challenging to even move forward.
Yeah, great points. And so go ahead and start the video, please. I think traditionally the thought always been save the bag, save the bag, save the bag. And as our techniques for secondary lens fixation have improved, my thought was yours exactly. There's not much there to say, or, it's going to be hard to save this in a way that I'm able to put a lens in securely over the long run. And remember, he's only 65, so he has a long way to go. If you're going to suture this to the wall of the eye, whether that's with Gore-Tex and or Prolene, you can run into issues there too. So I decided to take the whole bag. You can see here, don't pull out my eye at all and just eat the whole bag, and Cortex and all. So now he's aphakic with no capsular support, and without any vitreous in the eye, presumably. So I decided to do exactly what you said, which is go for intrascleral haptic fixation. My preferred technique is the Yamane, and I've learned a lot about this from my good friend Nicole here. You can see here, Nicole, I'm flaring my
I know, I
marks here.
saw
I'm
that. I'm
flaring
like,
my marks here
yeah.
because that's what you taught me. Putting in an AC
Well, that's
maintainer.
what Shin Yamane taught me.
Yeah,
So it's not
I learned
mine.
from him as well. I
Yeah,
understand. I understand.
yeah.
But
All right,
uh,
wait. Stop. Go
pause.
back. Pause the video. He just did something really great. We're gonna go back just a little bit. When you put your needle in, so first of all, you're bearing halfway vertically and perpendicular to the sclera, then you tunnel. You're holding your straight tires to feel kind of where the needle should stop at that quote 2 millimeters or 1.5 millimeters. And I think that that's a really big pearl that you may not even notice that you did.
Yeah.
So I,
Yeah, we teach that to our fellows, and I think it's a great way to sort of know where you are. I like to do it sort of sequentially. There's different ways to do this technique. I never want to feel like I'm going to lose the lens to the back of the eye. So this is a CT Lucia lens. I externalize one haptic and then and do the same thing then on the second haptic here. I bend the needle sort of strategically, and we've talked about this at meetings before to help create that backstop for where the haptic will go into the needle more easily, and then try to be gentle here, externalizing the second haptic as well, and then a gentle cautery to the haptics. I think an AC maintainer is key, and then I like to use just a BSS cannula to sort of help push that flange into the sclera. Sometimes if you try to just push it with a 0.12 or whatever, you can't really get good traction on it. You can see here I'm pushing the conj out of the way and then using that cannula to really
this is,
shove it into the
but
sclera.
this is huge. I was like, we need an instrument to help us bury that flange. And we already have it. And you
We
just
have the
figured it
instrument.
out. Eureka,
Yeah.
right there.
And then, causing the pupil to come down here a little bit. And then I always suture these wounds, put a PI in. This is also something that, not everyone does, but I feel like in a case like this, placing a peripheral iridotomy is helpful and protective against possible pupillary block and issues with iris chafe and whatnot. The other thing I've been doing with these cases is not going 2 millimeters back, but 2.5 millimeters back. I feel like I'm getting less issues with iris chafe on these patients. His cornea looks nice and clear here. Day one did not look so clear. fairly edematous, but he was doing well at day one. And now he's several months out, almost a year out, this patient is, and is 20/20. So we did
Wow.
really well with our IOL targeting, and he's happy. Now, does his endothelium look perfect? It doesn't, nor would he expect it to, but he's not having any AM blur, and is still doing pretty well. So that's my case.
That's awesome. There's so many pearls to take away from this. And, I think that the whole idea about keeping a capsule bag has to do with how long it's going to take you to restore it if you want to. The guy's already vitrectomized, so you're not wanting to keep the vitreous for vitreous scavenging, for oxidative reasons that Steve Safran has talked about in the past, like you would with a young Marfans or something like that. So you also have the experience of doing multiple Yamane procedures or intrascleral haptic fixation procedures, and you knew you could do it in a calm fashion. But one of the things that we always like to emphasize, which is what Liz said, is that if you're exhausted and you felt like you were in quicksand during that whole case, just stop, come
Yeah,
back another day, refer, and there's no shame in that game. And I always like to point that out because a lot of people will listen and watch and say, well, I don't know how to do Yamani that fast, and I only do 2 a year
right.
or things like that.
Yeah, I agree. I think one of the challenges here is knowing when to stop so you don't create more damage. Sometimes, you try to get it all done in one surgery and you end up actually harming the patient more than helping the patient. And that's sort of translated me to other cases too. I used to do a lot of like big combo cases, IOL exchange with
Right.
iris repair and an endothelial transplant. And I've sort of been staging those now. I'll do one part of it, let the eye settle, figure out
Yeah.
what's going on, and come back and do the cornea part later. And I think, it's really mindful, and I think it's better for the patient. I think they'll do better if you sort of don't try to hit a home run
Right.
in
And
one go.
the staff and the surgery center, they don't want you in there for 2 or 3 hours. They
Yeah,
want,
especially when it happens, like when you're not planning for it,
right.
right? Something like this, it throws a big monkey wrench in your day, and then you have cases to follow that you have to finish. So
Right.
trying to be efficient there. Yeah.
Sam, you make some really great points in terms of doing combo case surgeries too. When then there's like this extra layer of you also having to plan with retina, like where they should be placing their instruments so that it doesn't quite, so it doesn't hit your instruments.
Right.
Yep.
And then when everything gets ballooned up with the chemosis,
Mhm.
that
You guys,
can also be a challenge because that is kind of how we mark our landmarks, and then we're cutting things down. So staging it versus doing it simultaneously or by immediately sequentially and versus staging it a month apart or something, it makes a ton of sense. um, I also have noticed, and this is for me, um, I still like the CT Lucia. I know that there has been, those I've not experienced the rotisserie effect, but these are a few things. I do think that if the axial length is longer, or if we are also trimming the actual haptics more so it's more on stretch,
Mhm.
that could have lead to a greater propensity. Now, only anecdotally are we going to figure some of this out because I know that it's glued in and it's a little bit different, and that's why it leads to that. Or multiple attempts at trying to get it into the needle is
Yeah.
going to also lead to that potential. But on the other side, utilizing like an AR40 or the I61AO, the silicone Bausch and Lomb lens, that's also challenging too because it crimps very easily. So you have like one chance
one
to
shot.
get it in, one shot on goal,
Hmm.
guys, to
Yeah.
get it in. And if it doesn't get in
You got to start
properly,
over.
then you are trimming because then you have greater chances of decentration and IOL tilt. So there's a little bit of a game that you have to kind of decide. Like you either know that with the CT Lucia, you try not to trim too much because you don't want it to stretch too much at that optic haptic junction. And, don't choose a really long eye. If you're going to
Yeah.
be working on really long eyes, the Yamini may not be the best technique. Like if someone, when I'm working with 27 millimeters or longer, that's not the technique of choice,
Yeah.
See, for
So
me,
that's like another
yeah.
pearl.
And I try to look at axial length, but to me it's white to white.
White. Yeah, me too.
So if I have a white to white greater than 12.7, I'm going to a different fixation, whether it's CZ70, MX60 with Gore-Tex, or even 7.0 proline, polypropylene. But I fully agree, Liz. I mean, the PVDF haptics from the Zeiss CT Lucia are the best way to learn, the best way to be able to redock, the best way to be able to dock in general.
And the flange
But
is nice too. The little button's nice on that thing
the
too.
mushroom cap button is really nice too. You don't have to make it that big. The problem is, I've had 3 rotisseries.
Yeah.
And whether it's the lot numbers or, that we're just unlucky or what it is, but you take a fellow and you're like, you're going to do your first Yamani. And you're like, I'm so excited. And they do a perfect job. There's no redocking, there's no stress. And they come back like this. It's like
Yeah,
your heart. But the flip side is that it's hard to teach intraskull haptic fixation with
it
AR40,
is.
Yeah.
AR40
With
because
different lenses.
it's so nuanced. The PMMA haptics are so fragile. And some
And
of the tech
you find that they're sticky. I find like the AR40 ones are like super sticky. It makes it hard.
they don't dock in
They
the
don't
30
dock.
And they
gauge,
come out
30
easy
gauge
either. So
thin
like when
wall.
you're talking, yeah.
Yeah.
Right. And you know
So,
how we talk about angling it, to get
mhm,
in, and it's not like, we've all done at this point hundreds of, these
yeah.
cases, and they are very nuanced. And like even when you let go, you can tell you've already malformed it a little bit. It's no longer the same shape. Even if you grab it one time and you release it, you can see that it's much more malleable, and it is sticky. Even if you're not holding on to it too tightly, you have to be very, very exact in terms of how you hold on to it, knowing what to do with it, and so to everyone's point, but I like that cannula. That was it, a 30 gauge cannula that you used to push in? Because
Just a
20,
regular
I
20,
use
27 gauge.
27. Yeah.
27
27.
gauge. Yeah.
What else, another one that is a great way to do it, which, because I do use a high temp cautery, because I've seen that, with a bigger mushroom cap, yes, it can be more challenging, especially when you're utilizing different lenses. It can be difficult to bury, but I want a bigger one because I don't want it to go through the sclerotunnel for any reason. So I like creating a bigger mushroom cap, but making sure it's really well buried.
Yeah.
The MST forcep, if you use any of the MST instruments that we have to, obviously, or a Supermax grip or whatnot, the retinal instrument,
Yeah.
if
They're
you
Grace
open
Hopper.
it, if you keep it open and you use, because they're so thin, and you
Fine. Yeah.
keep it open, you can push it right in. It's
Oh, that's a
beautiful.
good one too.
It is
That's a good
so
one.
nice.
That's a real
So you
I will.
grip that sclera, and then you can keep it
1.12.
open.
And
And then you push it
yeah.
right in with the open
And
MST forcep. Oh, it's
I will.
so nice.
I will warn you. We've done that, and
it
it's gonna.
goes right through.
Well, no, we've bent them because it takes a
Oh,
Oh,
big amount of force to push in that the button sometimes. So just be careful. You're
uh-huh.
spending
that's
thousands of
true.
dollars on these
Yeah.
instruments that if you push in and you
Yeah.
bend, then
Oh,
the end the
I
end.
yeah. I
oh,
tend
I
to
haven't.
take down he's strong like bull.
Yeah.
I tend to cut down the conch like a
Yeah.
little buttonhole, and then I take a point 1 2 and grab the sclera, just like you said, Liz. And then I take straight tires and I use one side of the straight tires and push it in. But
Yeah.
I'm gonna try the cannula for sure. So Sam, if you can, kind of summarize, like, what are your top 3 takeaways of your Eureka moments during this case that made that Yamani so easy for you and made the transition so easy?
Yeah, so I think the correct lens is helpful. And I think just about the CT Lucia and the rotisserie thing, for me, it's been sort of random when it's
Yeah.
happened. It wasn't just long eyes, wasn't just complicated cases. It's happened in very straightforward cases as well. I think like it's happening. I feel like it's happening less because I do think it's the best lens for this. So having the right lens, I still check my haptics with my needle beforehand, which I didn't show here, but I did do that. I think having your marks correct and clean, which is easier in a one surgeon case versus a combo case. They don't get obscured as much. AC maintainer, super key. I still am a believer of the PI, and I know not everyone does a PI. And then making sure those things are buried is important. And then lastly, when you're targeting these lenses, remember, because they're sitting further back, you have to add some power to the lens, because the effective lens position now is more posterior, and that's going to create a more hyperopic outcome. So if you add power to the lens, you'll be more on target. I do warn all these patients when I'm doing it planned that, I'm not exactly sure where they're going to end up, because I've had patients end up a little hyperopic and way myopic, and sometimes it's just unpredictable. I think knowing what your white to white is super important for these cases. I write it down on my IOL sheet when I'm planning for it. And then just knowing that, things can happen. So these complex cases, I usually warn patients about possibility of things going a little sideways and us having to be a little MacGyverish during surgery to figure out a way to, get a lens in the eye. If not, wait, come back another day.
Great.
Yeah.
So
Yeah.
great. Well, thank you for joining us for this episode of OQC Eureka Moments. We hope that sharing these techniques, learning from Dr. Garg, will help speed that learning curve, and we can pass down these gems that have been gifted to us by our mentors and over the course of our careers.
And please remember to email us at quicksandchronicles@ascrs.org with any questions, feedback, recommendations. And as we mentioned earlier, please take the time to fill out that 1-minute survey linked in the description. It's so helpful for us to help with content and topic ideas for the future too.
And remember, every time you think you have the eyeball figured out, it's going to humble you.
But we do hope that these collective experiences will help us all develop that grace under pressure. Thank you, and we'll see you next time. Peace.
Bye-bye, everyone.
Bye.
Thanks for joining us for this episode of OQC Eureka Moments with Doctors Nicole Fram and Elizabeth Yu. Hindsight really is 2020.